Our center, kind of a little bit of the background of how it came about and how it came to be its own entity, and then kind of what it's looking like now and where we're trying to go going forward. But it's I hope that you ask questions as it goes along. Feel free to interrupt if you have questions as we move through. Oh, okay. So we're actually in the process of kind of revamping our mission and vision, but basically the goal is to be kind of this interdisciplinary center that provides multiple services for adults with IDD, and that's really based around primary care. We as you can imagine from the name and the location, are academically based, so we are part of a bigger academic center at the University of Cincinnati. So how did this come to be? So really, the initial clinic or person that this grew out of is the namesake of the clinic, Dr. Freeman, and he practiced at the center that we're at now. So it's still partially kind of a regular family medicine primary care clinic, and he just, because he had an interest and wanted to, had many patients with developmental disabilities of different types for well over 30 years and was really well known in the community. And so kind of built this natural base of patients with developmental disabilities in the center. And then over the last couple of years, it started to transition into something a little bit more formal. And so the initial thing that it became was more of a transition clinic. So the idea behind it as a transition clinic was to see patients transitioning from the pediatric system and then find them a home in the adult world that they could go for primary care. What ended up happening is that people didn't want to leave and they wanted to stay there for primary care. And so that's how it then eventually transitioned into the center that it is now, with providing ongoing primary care services. So the patients that we see come to us for true primary care. We do have an option of doing some consultative care, but for the most part, we see people on a primary care basis. And I'll talk a little bit more about kind of the other services that got added on. Unfortunately, about 2 years ago, Dr. Freeman passed away. And so that's how the clinic became kind of an honor in his name. So through that system, like I said, some of the identified needs, and this is still kind of a challenge that we're facing, is Cincinnati Children's Hospital is a really prominent, well-known children's hospital in the area. They have a lot of really complex patients. There are people that move to the area for Cincinnati Children's. And so there's a lot of those patients that are needing to transition to the adult system. And that demand, even with our existence, really outpaces the supply by quite a lot. In the recent meetings we've had with them, I think they have 900 about patients that could theoretically transition at any time now. And we have about 1,000 patients at our clinic. So this need is quite large. One of our ongoing challenges will be figuring out how to hopefully even out that supply demand curve a little bit. As I'm sure all of you are well aware of the significant health disparities that face this population. And then further upon that, in kind of the downtown Cincinnati area where we're based, there are a lot of other health disparities and a pretty diverse population that have a lot of different needs. And so really trying to figure out how we can best meet all of those needs. One of the biggest challenges, especially in the transition from pediatric to adult care, is this kind of drop off in like care coordination, care management, kind of the extra support services that are really well and widely available in the pediatric system that really don't exist in the adult system. And so part of that's a little bit of setting of accurate expectations as people make that transition, but also trying to meet that care management need for this population that has a lot. Yeah, so capacity is just really a big thing. And so we're trying to figure out how to both expand our own services, but also figure out how to better support other primary care doctors in the local area to meet the need as well. As I said, we're part of an academic system, and so we're part of this UCHealth system. And one of the really big advantages to that is the ability to coordinate with other specialist services. So we have some champions or some really close allies in a variety of departments, some of which end up being on occasion co-located with us or just common referrals. But having worked prior to this in a federally qualified health center doing similar work, the ability to communicate and coordinate with those specialists is really quite critical, and makes good care a lot easier. There's some challenges as well, obviously, with these big systems, but that communication among the specialists really helps us quite a bit. So these are kind of the services that we currently have, and it's always a little bit ebbing and flowing depending on funding that we're able to get, comings and goings of our staff and things like that. But like I said, the main base of the service is primary care. So everyone enters to our clinic through the primary care side. So if they're a new patient, they'll come to one of us, and then we will kind of set them up with the other specialty services or the other services within our clinic, as needed. And so some people need all of them, some people need some of them. It just really depends. The two most common ones after primary care are probably psychiatry and physical medicine and rehab. So we have 2 psychiatrists. They're both part-time within the clinic, that work in our center. And one of the great things is, like, on multiple days a week, I sit right next to the psychiatrist working in clinic. So there's really a lot of direct communication back and forth, and we'll have appointments often at the same time, back to back. Same thing with physical medicine and rehabilitation. So we have our PM and our doc here on Friday mornings. And so we'll have some new patients that will see us both together, or follow-ups. Again, just allowing people to come for multiple appointments at one time can really be pretty helpful. She's not able yet to do any of her procedures, like Botox injections, anything like that in our clinic right now, but that's kind of a long-term goal. The remainder are really kind of these extra support services that really end up being super helpful and really important, I think. But the challenge with them is just the funding. Since they're kind of non-billable roles, it can be hard to find ongoing funding to continue to support their work. But so far we've been able to, and so they're great additions to the team. The nurse care coordinator, she does nurse care management. She helps a lot with ensuring people have the right supplies that they need, DME orders, just kind of navigating the system with people, some of our most kind of medically and socially complex patients. Somebody that works really closely with her is our community navigator. And this role, I think, is so lovely and so essential. So she came from a local agency that she previously worked there, that provided like residential support, home and community-based services for adult patients with developmental disabilities in the Cincinnati area. So she's really well versed in the Medicaid waivers, the eligibility, what supports and services people might be eligible for, and helping navigate that process because it's so complicated. And so it is so nice to have her kind of set people up with community supports and services. In our area, it can be really challenging because Cincinnati is located on really the edge of 3 states. And so she has a tall order in that she really has to be pretty well versed in Ohio, Kentucky, Indiana, and all of the supports and services in those areas. So that can be challenging. The therapies, we collaborate really closely with them. They're not co-located with us, but we have kind of a set of really close colleagues that provide these therapies for our adult patients, and so we'll refer to them. The transition planning is really kind of a combination of all of those things. Depending on the state people live in, we do a good amount of telehealth, but it has to be located within the state of Ohio. As I mentioned, we do some consults. That primarily ends up being for patients that live far away but are hoping to benefit from kind of the specialized care or the specialized knowledge that we have at our clinic. And so we'll have people from across the state, or even down in Louisville, Kentucky, a couple hours away in some rural areas. And so they might come once a year, a couple times a year, to just make sure that there's nothing being missed or to ask specific questions about services, but don't come for our ongoing primary care, because obviously there's some challenges traveling a couple hours for your routine care. The one thing as of now, if they do a consultative model, they only see primary care. We haven't yet opened that up to all of the other specialty and supports and services. So this is our actual team. So like I said, we have 3 primary care providers right now, hoping to expand that, our 2 psychiatrists and physical medicine. And then these are all of those extra support services that I was talking about, as well as our program manager who helps kind of just navigate the inner workings of everything and make a lot of maintain our relationships with key partners and things like that. Laura, I didn't mention before, she actually works with Hamilton County, which is the county that we're located in. So she works for the Department of Developmental Disabilities and does some behavior support. So she's with us once a week. So if people need help getting labs drawn, or other like managing, being able to get through their clinic visit, that's really what her job is. We have a lot of community partners, as I'm sure you guys do as well, and we're really working a lot to rely upon those people to kind of guide where the clinic is going forward. So we have kind of a patient and family advisory board and steering committee, which is largely made up of a lot of our patients and family members, and then have really close connections with a lot of local organizations that provide support to our patients, as well as some national ones, which has been really helpful for just support, but also a number of community foundations have provided some really good funding. And I think given how difficult it is from a financial perspective, a lot of the philanthropy has been a really critical part of maintaining, especially some of those non-billable services. Yeah, so as I mentioned before, the main kind of goal or structure of us is to try to be kind of as patient-centered as possible and to really have that opportunity for collaboration. I was just talking yesterday with our psychiatrist about one of our shared really complicated patients and thinking how nice it would be to be able to sit in a room with a team of all of this person's other specialists because of their just really complex situation. And so even though we're not quite there yet where we can't get, 8 physicians in a room to talk about a case, at least we're kind of closer with a couple. And it really is quite helpful. I think for psychiatry, what we've noticed in particular is that the availability of psychiatric services in, I think, the whole nation is so short that one of the things that ends up happening is somebody might see myself or another primary care doctor for a behavioral or mental health issue. And because they can get into it, see us sooner, and then we can talk with their psychiatrist and figure out the best plan, even if they don't have the availability of that appointment. At the academic center, we do a lot of education and teaching, and this is really a pretty fundamental part of what we do and a big important piece of what we think is important as existing as a center. And so we have third-year medical students, fourth-year medical students, residents that all come through our clinic. The third year comes through their kind of normal family medicine rotation, and they spend time with us and the primary care clinic that we share space with. And then fourth year, we have an elective that students can do from anywhere from 2 to 4 weeks and spend that time in our clinic. And residents, it's on an elective basis as well that they spend time in our clinic. And then we have some didactic curriculum in the first two years of medical school. One of our goals as we're trying to figure out this capacity issue in terms of we can't meet the entire need of the area is trying to figure out how do we expand that education to other physicians, in particular primary care clinics to help meet that need, and how do we decide where patients go, who's the best fit for a center like ours versus, maybe the residency clinic with some extra support from us or things like that. And I wish I had the answer to that right now, but something we're in constant conversation about. Those are all the things I already mentioned. Oh, occupational therapy, we're hoping to have some students come with us both in the clinic and ideally at some point in the hospital setting to help people get through procedures that are otherwise difficult to do, help with kind of behavioral supports. And so that's not up and running yet, but one of the goals as well. So that's part of kind of this system-wide collaboration that I think has really taken off since we've been in existence. And so probably the best example of that is anesthesia. So we have a great anesthesiologist who has championed a workflow and a process to help support our Freeman Center patients who are getting anesthesia. And so basically the process is if we see them for a preoperative appointment or in advance of any procedure requiring anesthesia, we'll send them for an anesthesia consult, and they figure out a whole behavior plan. They figure out if somebody needs medication, what they need to do to make the experience more comfortable. And they've really done all of that themselves. And so that has really been a huge success, and we've gotten excellent feedback from our patients who have gone through that, and it's made the process a whole lot easier. And so our goal is to hopefully take that type of model, find some champions within the other departments, and see what we can do to help improve the experience in other places. Dental is kind of our next step. That is such a big need and something that people have a really hard time accessing, especially if they need sedation or desensitization for their dental work. We have a couple spots saved within the UC dental clinic for our patients right now so that they have a little more access. The hard part is just access to operating room or anesthesia services along with that. Usually, as with many things, it has to do with billing and the finances of that process. So we're really trying to figure out how to integrate that a little bit more and hopefully even co-locate services at some point. And then we're working on some research. We're collaborating with our research department and hoping to find ways to kind of quantify what we're able to do and learn more about our patient population. These are some of the big things, and maybe this can be jumping off points for discussion among the group, or if you have other questions, would love to hear them. But I think these are some of the sticking points that we're really hitting at this point, and what we're trying to navigate going forward. And so, like I said, capacity is really one of our biggest challenges. So the numbers have taken off. Sometimes I'll have 4 or 5 new patients a day, which can be overwhelming. And we anticipate reaching really our true capacity very quickly. And so part of our question is, how do we decide who qualifies for our clinic? What are the criteria, and how do we do that in an equitable way? But also, should we be doing other things more formally to prioritize health equity in other ways? So if there are people coming from other marginalized populations that maybe don't come across our services or don't seek them out as actively as some of our more privileged patients, what can we do to make sure that they can still have access to this clinic and wraparound services that maybe they would benefit from even more than some of our really, really savvy families? And then kind of system-wide, how do we address this on a system level where, again, Children's has more patients already that could be ready to transition tomorrow that we cannot accommodate. And so, how do we set up the rest of the primary care system, the rest of the hospital system, specialists, to be better prepared for this population? And I don't know, million-dollar questions, I think. The last thing I forgot to mention at this whole process, we are trying to recruit for a developmental fellow that will be a 1-year fellowship in developmental medicine. And that has been really challenging to find people that are interested and wanting to come do our fellowship. But if you know anyone, please send them our way. But that'll hopefully help both increase our access and train future physicians prepared to do this. And then really just, how do we measure if what we're doing is going well, what things we need to change? So that's kind of the end of the formal thing. I would love to kind of just have conversation and answer questions, thoughts from here. So I haven't been keeping an eye on the chat, so let me see if there's anything.
Thank you so much, Dr. Johnson. So why don't we go ahead and open it up? It looked like Dr. Mead has a question. Michelle?
Sorry, just wow. The extent of what you're doing is so impressive. I was just talking about what are the best practices, and clearly you've developed some of them. The idea of the patient as the center, the idea of co-locating, the collaboration. I guess, what are the key issues you see in terms of collaboration, or just, focus on billing? What is your relationships with the insurance companies, with the Medicare, the Medicaid, those various systems in terms of what is fundable, and how the acceptance of it by your system?
Yeah, that is something that we're pretty early in as well. So our medical director, Dr. Wong, is excellent at kind of developing community relationships and getting funding through philanthropy grants and things. And so while on one hand, it's excellent that we've had such great philanthropic support so far, and that's driven a lot of what we've been able to do. We still haven't quite gotten to the point where we've nailed the billing aspect of things and figured out how to make it a more financially sustainable model without that philanthropic support. We are hoping to create some better connections with the Medicaid system within the area to see if there's any way we can have like higher per member per month kind of reimbursement. Obviously, we have a lot of dual eligible patients that fall under Medicare and Medicaid, and so how can we really kind of optimize that financial reimbursement? I will say we've tried to work with our billing department on a number of occasions to see if there's ways that we can even optimize what we're doing from a billing perspective. And that is so much easier said than done. I always expected that they would kind of have a lot more pearls in terms of like, what kinds of things are we missing? Like, are there other areas that we can be billing for? How can we bill for some of these, like our pharmacist or dietitian? How do we bill for these other services that I know are being billed for elsewhere? And that has been, even from a system perspective, very difficult. So I think that is one of our big areas for future growth and improvement, is like trying to figure out the long-term financial model, and hopefully a model for other places that can make it more easily adaptable, because philanthropy has a role, but ideally not the crux of everything going forward.
Thank you.
Just to follow up on that question, this might be something you've already tried to explore and maybe advocated for. Through Medicare, they often, CMS will drive a lot of the high complexity codes. And I've been very perplexed that some of our more challenging to care for patients are not under that. And so those actually do make a huge difference in terms of how much money you get. And I've had continual dead ends. Just, it's kind of a hard beast to get, to tackle, and also to even break through to get somebody there. But I do think that is something down the road needs to be addressed, and acknowledge that the work you do, it's just as complicated as taking care of somebody with insulin-dependent diabetes, with retinopathy or nephropathy, and probably even more so just because of all the other things that you have to deal with, administrative forms. So I know you're probably already maximizing, I'm assuming, time spent. And there's a new one called the G2211, which is a continuity code. So it sounds like you've already kind of maximized all of the other stuff. The other question I have is opportunities to perhaps get training, cross-train people here at University of Michigan, medical students. We do have medical students that visit from other places to join our disability health elective. I would love to explore visiting medical students from here to go there.
Yeah.
That might help, just to have future applicants for a fellow, maybe as they complete their residency. I would love to maybe explore that. I don't know if that's a possibility.
Yes, we have had occasional visiting students. The process is a little bit clunkier for students outside of the UC system, but we have had some visiting students. So I think there'd be great opportunity and interest for people going both directions, hopefully.
Okay. I would love to maybe just find point of contacts and see how we can do that.
Yeah, definitely. Absolutely.
Awesome. Okay. Are there other questions from the group? And Michelle?
What type of accommodations do you have built in? And those may be, with how you've created your environment to behavioral training or training for behavioral issues.
Yeah. The behavioral stuff is probably one of the biggest ones we are trying to address, and that's an ongoing thing. One of the things that all new patients do is we have a kind of behavioral safety questionnaire that people fill out that goes through their kind of history, if they have any history of behavioral services or behavioral issues, in particular safety related ones, because we've, as you can imagine, had a couple of incidents that have come up in the clinic. So everyone does that when they come, and then our social work or behavioral health specialist goes through them and creates a flag in Epic for, in particular, safety related issues that can be clicked on system wide. Beyond that, you can see the whole questionnaire. So like I can see the whole questionnaire in, where does it end up in the chart? I forget exactly. I think it's in the social documentation section. So I can see that whole questionnaire before I see the patient.
Does that ever impact people's willingness to see the patient?
I will say that the questionnaire is very new. So I don't think we have enough experience with it just yet in terms of like specialists. I think that one of the other big thoughts about the flag, or I know anesthesia uses it for those plans that they're creating, but that would be a really interesting thing to know if that has negatively impacted people in any way.
It sounds like your clinic is prepared for this. It has specific protocols and pieces in place, but I could, you know.
Could see what, yeah. That's a really, I'm now trying to think of like how we would get feedback from people other than just patients coming back and saying they had trouble. So there's that questionnaire. Space-wise, we have a couple of larger rooms that have windows, but our current space is really lacking in terms of in a variety of ways. It is both physically accessible, and we have those bigger rooms for those that need it from even kind of a behavioral perspective. But we only have 3 of those larger rooms with lower exam tables and things like that. We do have funding to build a separate clinic space. And so we're working with some architects and designers that have some knowledge in terms of, I guess, more of like a universal design from a behavioral and accessibility perspective to hopefully make our final place much better. Because, we're just kind of subject to the space that we have at this point in time, and we've done what we can with it, but it's not perfect. It's on the 4th floor. The parking garage is horrible. There's not a lot of, there are handicap parking spots, but there's not enough of them right outside the building. All those kind of old building type of issues that come up. We have some sensory, a whole kind of stack of sensory toys in our clinic. So, little fidget toys, kind of kaleidoscope like things, a whole set of those things that our patients can use while they're there. The behavior specialists from the county that I mentioned, some of our MAs are able to do blood draws within the clinic, so they don't have to go down to the lab, because the lab has been we've had some problems in both directions, I think, from the lab. Some issues, as you can imagine, where patients have become somewhat aggressive in the lab, and then some refusals on behalf of the lab staff to work with our patients. So while we're working on kind of training them better, we're also trying to accommodate and meet the need up in our clinic where it's a little bit less stressful for our patients. We've all gone through CPI training. So crisis, what does it stand for? Basically nonviolent intervention, physical intervention for kind of worst case scenario situation. I'm fortunate that I have not had to even think about that yet, other than the training. So hopefully our main goal is prevention, but obviously anything can happen, and we have like emergency switches kind of calls within the rooms just in case. Pretty rare, but something that we're trying to be as prepared for it as we can, and trying to talk to other clinics about how they deal with that. And I think we've heard from a number like that it's just a hard thing, and nobody has kind of the perfect answer, but doing what we can. And we do have Hoyer lifts and wheelchair scales and the physical accommodations.
Great.
Yeah.
And I can just keep going on and on if there's no one else raising their hand.
Yeah, please.
So what is the relationship in terms of self-advocates, or the focus and the discussion with the patient themselves versus the involvement of family or other caregivers?
Like in the clinic appointments, or like our advisory?
Right, across the board.
Yeah, so I think one of the big things in our clinic, even as we get learners through, is that the standard is that we always speak with the patient first. And so I think one of the strengths of our clinic is that that's just kind of a known, the communication on that level when the patient's in the clinic is well known among us, it's well known among the staff, and we've gotten direct positive feedback on how that goes for people. Saying like, wow, that was like one of the first times somebody talked to me first, kind of thing, which is unfortunate. And our staff is trained on that as well. So our front desk staff has really improved on that over the past couple of years, as have our medical assistants. So I think within our team, it's pretty good. Our advisory groups are a mix. It's actually been a little bit difficult. We really want to get as diverse of a group in the advisory group and steering committee as we can. And it's been a little challenging to do that for a variety of reasons, for patient availability, transportation, all the same things that are challenges for all of us when we make commitments to new things. But we have, how many? I don't know the exact percentage or number, but it's at least a third, I believe, of our advisory committee is our patients themselves. We obviously have a whole subset of patients, a pretty large one, that really can't communicate on their own, or they need support communicating. And so we do have a lot of family members as well for that reason, to try to get representation from as broad of a group as we can. That's always something in this work, and I'm on the board of FAADM trying to figure out how do we really get good input from people with this like wide variety of communication needs, and some who really have pretty minimal communication themselves. So that's an ongoing work in progress. We unfortunately had a situation where we had a meeting of one of our advisory groups in a different clinic where they had a conference room, and what happened was all of the self-advocates that went to check in at the front desk and ask where it was got sent up to our clinic. And then anyone without a disability got sent back to the correct conference room. So it's there's still work to be done, to say the least. But yeah, I think we're making some decent progress in that area.
How about issues of reproductive health? How are those addressed, and what type of general training, outreach, standard practices do you have?
Yeah, so we do what we can in family medicine within the capacity of our clinic, I think. That is somewhat limited just by what we have available in the clinic. And so we have kind of basic contraceptive counseling, and can do, birth control pills, and depot shots is kind of the capacity, patches, things like that within the clinic, pap smears, all that basic stuff. And then we do have a pretty close partner in OBGYN, and our patients have had decent experiences going over there. They do have good capacity for, I guess, adapting for physical needs, and using sedation or anesthesia as needed. It is still something I think is not by any means perfect as of yet. Sometimes it can go either direction, where I've seen where I wish they would do more for a patient, and vice versa, where sometimes I think they're, wanting to do an exam under anesthesia just for a pap smear, and I'm like, I don't know, like, if that, maybe we can think about how to better either coordinate other services that somebody might need under anesthesia, things like that. And so we're getting a lot better at coordinating those things when people need anesthesia, but not perfect. So that's an area I think in particular for reproductive services that would be helpful. I haven't had many patients in my time here yet that are looking for true maternity care, or have interest, or have gotten pregnant within our clinic yet. That I'm interested to see kind of how that goes, because I've had mixed experiences in residency and at the place that I worked before with how open people are, and the reception that people have when they're navigating becoming a parent, or interest in becoming a parent with some sort of disability. I think because we have most of our patients have some sort of intellectual disability as well, that's why it's not come up quite as much for us, but I think something that we'll be needing to think about.
This is Mike. I'm assuming you probably are well connected with Dr. Kara Ayers.
Yep.
So I know she's very interested in that topic as well. And in addition to the parenting aspect, I have a separate question. You have a really wonderful team that actually helps you, whether it's social worker, you have a dietitian, even behavioral health coordination. So here we have community mental health. And so that has been a little bit of a disconnect because we often have to go through them. They're not really well integrated or connected with our clinical team. So I was curious, it sounds like it's a different model. It's when in-house, sounds like a lot of warm handoffs.
Yeah.
If you could maybe expand a bit on that. And then the second one is, given dietitian and other individuals, have they developed resources to train other dietitians? I know we're always struggling with people who are perhaps more knowledgeable how to manage people with IDD or even other types of disabilities. So I know that was a multi-pronged question. So
Oh yeah. In terms of psych, yes, I think that's kind of probably the biggest collaboration and the biggest strength of the clinic is the integrated psychiatric and behavioral health services. So if people come through primary care as a new patient and they need psychiatric care, then I will get them set up with our psychiatrist for a new patient visit, one of the two. One is full, so it's really the second one. And then also we have the social worker who acts as a counselor and provides counseling services. She's probably one of the biggest assets from a counseling perspective because she's really well experienced in all the different communication needs that we have. And so a lot of people that have never been able to find a counselor that's willing or able to work with them in an effective manner have that opportunity. And so that's really quite a gift. She is also full though, so we already have a wait list for her services. So that's the constant challenge. Psychiatry, what we're looking at, because we're close to being full in that perspective, is how do we best optimize kind of this relationship between primary care and psych. And so, I think most people who have separate primary care and psychiatric services will go to primary care for primary care and psych for psych and ongoing psych, even while they're stable for ongoing prescriptions. One of the things we're anticipating kind of needing to do is a lot of times having somebody maybe go to psych for a duration to get to this point where they're more stable and well controlled, and then maybe handing back to primary care for management with kind of question support as needed and or referring back to them if something comes up again, just to try to optimize the use of that resource as much as possible. And so in that sense, our ability to work together, sit next to each other, talk a lot, I think is going to be the only way that's going to work very well. But that's kind of the goal of how that will look going forward. And then, the second question, as far as I know, so our dietitian just started about a year ago, so I don't believe she's done anything super specific in terms of educational materials. We've also kind of had to think about how best to use her time. She splits time with our clinic and a GI clinic. And so we use her primarily right now for enteral nutrition, so G-tube feedings, ordering supplies, figuring out what formula, water, all that stuff that people need. If she has time, she'll do, dietary counseling, weight loss, things like that if people are interested in it. But it's that's a pretty small part of what she does because we need more of that support from the enteral nutrition perspective. I'd have to ask some of our other people if I don't think they have specific materials, educational materials for outside people, but I will check with them.
thank you so much. Yeah, no, also one of the things I raise is that just trying to figure out how we can just assist with the medical education. So kind of return the favor. Often I invite outside presenters and likewise, just because you're doing some really cool stuff that we can certainly learn from. Can we provide something in return? Can we develop resources that could go even beyond just our two institutions? So
Right.
anything we could do to support that, I think would be really valuable just to help our support team be more effective to care for these individuals.
And I don't know, we just got off, as I said, the phone with the or out of the Zoom meeting with the Blue Cross Blue Shield, their social programming. And they were very interested in how they can help other clinics, other centers, federally qualified health centers and others become more accessible
Yeah.
to individuals with disabilities. And so it may be that there are funding partners, insurance, the state that can also help in terms of thinking about these type of outreach and engagement.
Definitely.
Really exciting.
Yeah, absolutely.
Others have questions? Yeah, I know, don't be shy. If you have questions, feel free to put it in the chat or just raise your hand.
How about, I know I keep asking questions, just
Please.
you're doing so much. How about older adults? What is the transition like for folks who may, rather than just the transition to adulthood, but the transition to older adulthood, and especially we're worried about dementia on top of other issues where, there wasn't independence to begin with, but additional issues or challenges.
Yes. That is something that we deal with a lot as well, and is still a big challenge. We have had some presentations and have worked a little bit with the National Task Group. What is their full acronym? National Task Group on Aging and Developmental Disability Practices, NTG. They have a variety of tools to look at early diagnosis, support, and things like that for people with IDD who are dealing with dementia or who are in this aging process. They're a little bit cumbersome. We haven't quite figured out how best to use them in the clinic setting because they're pretty long. So we're trying to figure out really the workflows and whether or not those are tools that we can use on a consistent basis and benefit from. One of the goals would be to get baseline evaluations on people initially and then use it as a reference point. So if somebody then comes back later and is having concerns, that we have something to compare it to. So if we can get that to be a routine thing, then we'd be much better off in the diagnosis process, I think, because I think that's one of the biggest challenges. One of the things that happens right now because we're new is that we get a lot of new patients in some sort of either anywhere from a small to a very large crisis when they come to us as new patients. And so without that background information, you're really trying to see how this compares to their baseline, which can be varying degrees of challenging depending on who comes with them, et cetera. I'm sure all things that you're pretty familiar with as well. So that's still a work in progress. We do fortunately have some great neurology support. We work pretty closely with a physician in the UC system, Dr. Foster, who's a neurologist, and he does a lot of these more thorough evaluations for dementia and aging-related decline in people with Down syndrome and other developmental disabilities. I believe he has a family member with Down syndrome as well. When I learned of his schedule, I think he sees 3 patients in a half day, and I was wondering how he came to have such a lovely schedule, but he does really thorough work, obviously. And so that's been a great resource. He also helps us. So we have, unfortunately, a good number of people with Down syndrome regression disorder. And so we have been able to get IVIG or really specialized care for that as well. So we have a couple of people that really come from pretty far away for that coordination, even across from Cleveland, which surprised me given that Cleveland Clinic is right there, but I've heard they even have a hard time getting the IVIG treatment for that. And so we still have room to go, but we have some good colleagues that help us with those things.
I'm just wondering, just been thinking if there's, or one of the things we were brainstorming, a room for more of a specific transition program for older adults, for training people, their families, thinking about creating systems around that.
I think there should be, because at least anecdotally, what I see a lot of, or one of the things I feel like is a huge need, is support in terms of navigating the systems of care and you know, what do you do when somebody is aging and they're, you know, having memory decline and they come in with their 90-year-old parents who haven't thought at all about where they're going to live or what the next step is. I still personally find that very overwhelming because it's just such a big thing to navigate. And even though we have longer appointments, 30 minutes an hour, it just never seems like enough to really delve into like helping support people really almost more from this social home and community-based services perspective than even from the healthcare. In some ways, the health part is easier when we have the resources we do. But that like really on the ground care support, I personally would really like to work with the Medicaid waiver services agencies and things like that on a whole and figure out how do the true medical systems and the home and community-based services systems work better together, because I feel like that there's a huge break in those systems, and just it's hard to communicate back and forth as well as we probably should.
Okay. Thanks.
So we're getting close to the end of the hour, so I just want to be mindful of everyone's time. So we have time maybe for one more question. And Emily, I don't know if there's anything you wanted to learn on our end. I know we have connected, and I know you also connected with Dr. Marsoff as well.
Yes, I don't think I have other big things right now. Yeah.
And then also just let us know, I think I already shared some resources for the disability accommodation tab. It might be useful
Yes.
for you,
Do.
especially capturing some of the dual disabilities, whether it's sensory, in addition to the intellectual developmental disabilities. So feel free if there's anything, that could be
Yeah,
added.
I definitely will follow up with you on that.
Yeah, sounds good. Okay, well, if there's no further questions, I want to thank Dr. Emily Johnson for joining us. As I already mentioned, I think many of you are just really blown away by this program, the scale that you're actually in terms of providing care for the state of Ohio for patients with intellectual and developmental disabilities. So it's incredible work that you're doing. So I would love to stay in touch. Certainly think about ways we can have visiting medical students, maybe even residents. I know we have kind of chatted about maybe having a field trip for some of those who are interested. So more to come, and I'd love to be in touch.
Yeah, likewise. Thanks so much, everyone.
Thank
All right.
you.
Thank you again.
Thank
Bye-bye.
you.